welcome to the About the Face podcast, sponsored by the American Academy of Facial Plastic and Reconstructive Surgery through the Facial Plastic Surgery and Aesthetic Medicine Journal.
Good morning. This is Alyssa Ovaitt here with Clint Humphrey to talk about our article, The Impact of Using Intraoperative CT on the Number of Surgical Approaches Used for ZMC Repairs. We are both facial plastic surgeons who tackle complex facial trauma at our institutions. And in brief, this project retrospectively reviewed practice changes over a decade before and after starting to use intraoperative CT to better assess reduction of ZMC fractures. In the period after the introduction of intraoperative CT, there was a statistically significant decline in the number of incisions used to expose and repair these fractures, driven largely by the reduction in periorbital approaches. So, Dr. Humphrey, could you start with a little background about how these fractures were managed in the past before you started to use intraoperative CT?
Good morning, Dr. Ovaitt. Thank you. Sure, I can talk about how we used to repair these fractures before intraoperative CT. So traditionally, we approached the ZMC by a incision inside the mouth, a gingival labial sulcus incision that has very low morbidity, and this gives you access to the zygomaticomaxillary buttress. And then the additional incisions would be either a lateral brow or upper blepharoplasty incision that gives you access to the zygomaticofrontal suture line and also an ability to visualize the zygomaticosphenoid suture line. And then finally, the transconjunctival incision has really been the workhorse to visualize and plate the infraorbital rim, and then also to see inside the orbit to repair the orbital floor when that's necessary. And a lateral canthotomy and cantholysis can be added to that to even further expand the access you have to the rim.
Perfect. And so why intraoperative CT? Why do you think that this is an important study to investigate, knowing that past and where we are now?
Yeah, we just started to notice how much we were using it in our practice. And in the beginning, we were just using it for the most complex cases, but then we felt like there was utility for a broader range of injuries. And we noticed we felt more confident about the reduction when we left the operating room. So we had this strong feeling that it was improving our outcomes. And when you start using technology like this, you want to make sure that you're not just starting to feel dependent on it, that there is, some kind of real advantage. And, you want to know that the expense is justified. You want to know that you're not, unnecessarily spending a longer period of time in the operating room to use this technology, and that there are, actual advantages to the patients. And so we have three facial plastic surgeons here at the University of Kansas, and we started to talk amongst ourselves. And as we discussed it, we felt like the real concrete advantage was that all of us were starting to use fewer surgical approaches when we were treating these injuries.
Great. And when did you actually first start to use intraoperative CT?
So I don't know the exact date, and we actually didn't have much of a hand in it when they first obtained the intraoperative CT. They had obtained it for the neurosurgical and orthopedics colleagues for use in their spine cases, but we began to see colleagues around the country that were talking about it. And so about 10 years ago, we began to use it on select cases. And then, as I said before, we began to expand the indications for using it after that.
And expanding upon, our last topic on this a little bit, how do you think that this has helped your patients? How has it changed your practice and affected your patients?
Yeah, so we already talked about how historically you had these really three different areas, different approaches you could use to repair ZMC fractures. And while it's true that you can use this access to, put additional hardware in to place plates and fixate the fracture, the thing you really need these approaches for with ZMC repair is to visualize in 3 dimensions all these different areas to make sure that the fracture is appropriately reduced. And as we began to use intraoperative imaging, we realized we can instantly see the reduction completely in all these different areas without making additional incisions. And it seemed like we had this real opportunity to decrease morbidity for the patients because, less incisions, less pain, potentially less time, executing the approaches in the operating room, a reduction in complications from the approaches, especially with incisions around the eyelid, when you can run into complications like scarring of the lower eyelid and lower eyelid malposition.
And I know we didn't look at this in our study specifically, but anecdotally, have you noticed changes in the duration of these surgeries using intraoperative CT?
Yeah, my gut instinct would be to tell you that it's made the operations shorter, because we're performing fewer of the surgical approaches. But what we actually found in the study was not that it decreased operative time, but it definitely did not increase the operative time. There was negligible effect on the amount of time the surgeries were taking.
And do you find it relatively easy to use the scanner for those who haven't been able to use an O-arm or something like that in their institution?
Yeah, I mean, the first time or two that you use it, definitely it might take 10 or 15 minutes, to figure out how you're going to position the bed and how it's easiest to bring the machine into the room. But once you have a crew of experienced technicians operating the machine and kind of where everything needs to be to obtain the scan, probably takes about 5 minutes to obtain one of these intraoperative CTs.
What do you think is an interesting finding from your study or something that surprised you about the data?
Well, we were excited to find that it showed essentially what we thought was happening, that we were using fewer surgical approaches. But I think the exciting thing was that the approach that it decreased the most was this transconjunctival approach and the canthotomy incision, which we would consider to be the most morbid of any of the approaches used to repair these fractures.
As someone who worked with you in a location, that has intraoperative CT and now working at a hospital that does not have it, I've definitely noticed a difference in my practice patterns. I wanted to chat about that a little bit with you as well. I find myself now using more incisions. I likewise feel that, my operative time increases sometimes with the exposure of all of these and sort of taking the periosteum off of the fractures and plating, in more locations without the option to review the reduction alone with a CT scan in one approach. And so I think it's an interesting conversation to think about it. I do think, I feel I have become a little less aggressive if I feel great about a reduction. I think some of the fractures, these fractures aren't created equal. Some are more simple than others. And I just wanted to kind of see what your thoughts are on surgeons who might not have access to an intraoperative CT scanner, what you might suggest to them, any advice of what they can do at their own institutions.
Yeah, that's something we definitely thought about as we were writing the paper. The realization, as we talked with other people, that this is not technology that everybody has access to right now. Definitely an increasing number of institutions have it, and certainly academic institutions, but community hospitals and some academic institutions do not. As I talked about before, the way that we initially obtained it was not through any of our own efforts, but because the hospital had acquired it for the orthopedic and spine surgeons. I guess I'd turn that back around to you, Alyssa. I know you've been lobbying a little bit at your own hospital to try to acquire the technology. Do you have any advice for surgeons that are interested in using this and don't have access to it right now?
Yeah, it's something I'm still working on. And I think the key really is understanding the value that this would add to your own practice, but also to other providers at your hospital. And so here, been trying to speak with my colleagues in neurosurgery and orthopedic surgery, and even within our own field of ENT, neurotologists, and other people who might find it beneficial to use an intraop CT scanner and to work together on it because it adds value for many people. And I'm at a place where there's high volume facial trauma, and so many of us that do this type of surgery would find it beneficial, but it goes far beyond that. And I think the alternative option to something like an intraoperative CT scanner could be a portable CT scanner instead of a true O-arm. There are other options as well. And if you don't have these, would still consider a postoperative CT scan.
Well, hopefully our publication will provide some, hard data for surgeons that are out there to show to, appropriate committees and so forth that they're at their hospital that there are real advantages to having intraoperative CT.
Absolutely. Absolutely. So, what do you think is on the horizon for us, to improve our repair of facial traumas in the future? Or do you have any plans for future studies?
Well, the technology is changing the way we treat these injuries in so many ways. And, intraoperative imaging is not the only thing out there. Another tool that we are using more and more is virtual surgical planning. This is something we really use just for the most complex injuries, at least right now. The reason that it's become more useful for acute facial trauma is that the technology has advanced to a point where even things like custom implants can be produced within a period of days rather than the weeks that it used to take. This is not something totally new. This has been used for head and neck oncology or by head and neck oncology for quite a while, but they have the luxury of having a few weeks sometimes to wait for something to be produced. But as I said, as the technology has improved, it's become more useful for acute injuries, and so this is an area I see us using more and more, and something that we are examining in our practice.
Absolutely. Yeah. Especially in those really complex traumas. That's great. Well, thank you so much, Dr. Humphrey. Always enjoy catching up with you. And I look forward to hearing more about advances in this realm in the future.
We'd like to thank the authors for their commentary and thank you for listening to our podcast. If you'd like to explore more, please feel free to check out the article in print at the Facial Plastic Surgery and Aesthetic Medicine Journal or online. We'll catch you on the next one.